ask the question, well, why did this all happen? Who's at fault? Well, on the one hand, you might say, well, it's the fault of the nurse. He should have checked. Well, the thing is, there's a huge reams of research, human factors and that sort of thing, which say that asking people to check, to be careful, is completely unreliable when it comes to guaranteeing safety in any situation, patient safety or anything else like that. And then, aside from asking someone to check, think of all the other human factors, tired, dark, rush, adrenaline going, all the other things, which really compromise our ability to be careful anyway. So you say, well, can you really blame the nurse for not checking enough? And what's enough? Is it check 3 times, check 4 times, check 5 times, get another nurse to check? You say, no, maybe it's not entirely the nurse, but maybe it's the pharmacy. Because after all, the pharmacy is directly responsible for presenting medication to nurses to use. And they're the ones who put the medication in the same place close to each other and present it in vials of the similar color and shape and weight and size and all of that. But if you ask the pharmacist, they're likely to have protested, what did we do wrong? Oh, nothing, it turns out. There was no indication of contamination. There was no indication of over or under concentration. There was no indication of mislabeling. You say, well, what did they do wrong? Well, they did nothing wrong either. But how do you resolve that problem? You have pharmacy having done nothing wrong, nursing having done nothing wrong, and Mrs. Grant dead. You give it a little more thought, you realize that the issue is not pharmacy doing nothing wrong from the perspective of pharmacy. It's pharmacy doing everything wrong from the perspective of nursing. Putting medication in such a way that it's very, very hard to tell one medication from the other when it's very hard to make any kind of determination, tired, in the dark, in a rush, and so on and so forth. So there's a couple of lessons we take away from this. The first is, when you're designing a complex system, you have to design the components, absolutely. People have to know how to do pharmacy work, people have to do nursing work. But you can't design the components alone. You have to design the components one relative to the other. How do you do pharmacy work not from the perspective of pharmacy alone, but how do you do pharmacy work from the perspective of what nurses need, what nurses are capable of accepting, and also what's unacceptable for nurses to be successful. So there's a structural issue. Design the pieces relative to the whole. But there's another piece. You might ask, son of a gun, what a tragedy about Mrs. Grant. But what are the odds? What are the odds? Well, it turns out the odds are higher than any of us would find comfortable. Several thousand patients a year are killed by mismedication when hospitalized. But it goes beyond that. You see, the author of this case study, a doctor named David Bates, has done calculations based on other studies as to what else goes wrong with medication. And he comes up with ratios something like this. So for every error which leads to the death of a patient or an injury, certainly as was the case with Mrs. Grant, there are tenfold errors which have the potential for serious harm. So let's say an example of that might be a nurse inadvertently picks up a multi-dose vial of insulin instead of heparin, fills a syringe with it, and for some particular reason, right at the last moment, that nurse doesn't inject the insulin into the line, like unfortunately the nurse did in the Mrs. Grant case. Or a nurse may pick up the wrong medication, fill the syringe and inject it into the patient, but it might be something like an antibiotic where the patient doesn't have an allergic reaction, so they're fine, but it has certainly had the potential for serious harm. So we have the one error which leads to death or injury. We have the 10 errors which have the potential to lead to serious harm. But then for each of those, there's tenfold more. So now we're up to 100 errors which don't have the potential for serious harm, but errors nevertheless. So an example of that might be the nurse who picks up, again, this multi-dose vial of insulin, but before even putting it into the syringe, notices that he or she is holding the wrong thing and puts it back down on the meds cart. Now those ratios, and one error leading to a death or an injury, 10 errors having the potential to cause serious harm, and 100 errors with little potential to cause harm, it really begs the question, you've got about 110 warnings for every serious outcome. And leads us to the question then, wouldn't it be nice if healthcare professionals listened to those 110 warnings that there was a vulnerability in the system and did something to solve for that vulnerability before someone actually got hurt? Maybe the insulin and heparin are separated. Maybe they're color-coded, different size, different shape, whatever else it happens to be. Done something to make it easier for nurses to do the right thing, make it harder for them to do the wrong thing. Say, well, what actually happens? Well, I've got a colleague, her name's Anita Tucker, who actually answered that question. She shadowed nurses for some 300 hours, taking minute-by-minute notes as to what nurses do. And just for the nurses who are watching this, just rest assured, the rest of you, the nurses are not unusual. It turned out Anita Tucker followed nurses, but this could be true of anyone in any profession.
When nurses did their work, they suffered these disruptions, these operational failures all the time. It's a perfectly normal part of the experience of being a nurse.
You say, well, think of all these opportunities to make things better. So what do nurses do? What Dr. Tucker found is that 90% of the time when a nurse encountered one of these operational failures, he or she simply worked around the problem. You know, if they needed gloves and the gloves weren't in the room, they went down the hall to get gloves. If they needed gowns, they went somewhere to get gowns. If they couldn't find gowns, they were very, very careful not to lean against the patient while they were changing the dressing. They worked around the problem. 90% of the chances to make things better got tossed away. But you say, well, that leaves another 10%.
If Dr. Bates' math is right, if there are 110 warnings for the one death or injury, we're still left with some 11 warnings which haven't been discarded. Wouldn't it be something if those 10, 11 warnings actually led to some corrective action?
So we asked Dr. Tucker again, what did the nurses do with the other 10%? Well, it turned out, and as much as we would be thinking, geez, call attention to the problem, tell a manager, tell a charge nurse, call up the pharmacy, explain that there's a problem. The other 10% of the time, when a nurse couldn't work around the problem by himself or herself, that nurse asked a friend for help. While you're down the hall, can you get me some gloves? While you're over there, can you get me a gown that fits? You know this, doctor. Can you help me decode this handwriting? You know that patient. What do you think the doctor really intended to be the treatment this evening when I can't reach the doctor during night shift? 90% of the time, the weak signals that something's flawed in the system got dismissed. The other 10% of the time, the weak signals got dismissed with the help of someone else. And here's the thing.
Having this conversation about Mrs. Grant, we all know the desirable thing would be for all those 110 warnings to get called out before a patient gets killed.
And we also know from experience that nurses who dismiss these things don't do it because they're malicious, don't do it because they're mean, nor are they lazy. They do it because they're doing exactly the right thing in the moment, trying to meet the needs of the patient.